all protocols observed, because I know there are people of high ranking order, and this is healthcare, we have structure. So all protocols observed, and it is my pleasure to be here this morning, ladies and gentlemen. Like Louis has said, yeah, and you'll forgive me, ladies and gentlemen, because there are so many doctors. So I can't say doctor this, doctor that. You understand all protocols? Observed. So I'm not disrespecting anybody. But as Louis has said, the subject of leadership, ladies and gentlemen, is a serious one. When I was coming for the conference, and I've been having thoughts going through me for the last 1.5 months, when I got the invite to moderate this particular session. And I looked at the subject, championing quality, and I asked myself, because we have teachers in the room, when all of you are going through school, did anybody teach you bad quality? I don't think so. But what happens when we come out to practice? Why do we let things go? Because we do know what wrong and right mean. The word is accountability, ladies and gentlemen. Where is it? I've run a healthcare institution. I've seen when it works and I've seen when it doesn't work, ladies and gentlemen. But how do we ensure that what we were trained, what we have, subscribed our lives to is upheld, because that is our profession? When do we take action on the uncomfortable part? Because we know. How do you uphold quality? And the word is uphold. Because you have been taught, you have been certified, you have passed, you are out there in whatever you do today. To me, it all boils down to a question of leadership. There's no chicken or egg here, ladies and gentlemen. But we just have to look ourselves in the eye and ask, what is the right thing to do, and do it. So leadership is close to my heart. Healthcare is close to my heart. Having been in the sector, non-clinical, but everything you learn. And it has been a pleasure to work with many of you. But healthcare is a system. And this system is made up of so many different pieces, of which you are part of. But the problem with our system, ladies and gentlemen, is that it is fragmented. Because everybody has a part. But do these parts want to work together? So the question is, for the pharmacists in the room, are you taking a rightful place in shaping this discussion? I was having a conversation with the CEO yesterday, Daniela, last night. And I asked her, outside of we'll call them physicians for this discussion, because I'm not saying doctor because you're all doctors. Outside of the physician, who undergoes intense, long periods of training after the physician? Who is it? Who is it? Pharmacist. Are we visible at the leadership table? That is the question. Because to me, the difference over here means nothing. It means that what you do is so serious that we have to try and test you for so long before we send you out there to confirm that you can actually do it. But then when you come out here and are looking for leaders, because leaders are hard to find, ladies and gentlemen, let me tell you. And I've been there and I've tried to hire many. If I've seen 5 pharmacists coming to say, I want to be a leader, in my era, it's rare. 5, and I ran the business for a long time. So today we're here to talk about leadership and governance in UHC. And UHC is another big one. But we're going to unpack that, as we talk this morning. And I've got a great panel of who I'd like them to come in front, and I'll introduce them after they've settled down. So please, ladies and gentlemen, I think it's ladies are domineering here. So ladies and gentlemen, please come and take your seats, please. As you can see, ladies and gentlemen. And to the gentleman in the panel, there's a common saying that I like. There's a common saying that I like. We might be outnumbered, but we're never outgunned. So today we're not going to go for the vote, we're just going to go for the quality of the conversation. So by name, I am Mark Achola. I am a leader, ladies and gentlemen. My business is the business of leadership today. I am a coach, I am a trainer. I am a builder of organizational leaders in Africa. I believe in Africa. I believe Africans can do it, but more than that, Africans must do it. That is me, that is what I believe, and that is why I'm here. Now, I've got a great panel of leaders. So I'll start with Dr. Nyalita, Anastasia Nyalita. And Louis, just to make sure that the rapporteur doesn't say he just came and had fun, allow me to read, ladies and gentlemen. So Dr. Nyalita is a registered pharmacist with a master's degree, an MBA. Yeah, so she's actually going to business school, which I think is great. And is a certified corporate governance trainer. So governance, is also a challenge. How do we just structure organizations? I think that's important. She's currently the chairperson of CAPI, that is the Kenya Association of Pharmaceutical Industry, a member of the Kenya Healthcare Federation, the board, she's in the board, a member of the Council of International Federation of Manufacturers and Associations, and of course being members in other boards on a non-executive basis. She has extensive leadership, technical and commercial skills, and experience gained both locally and internationally. So definitely, I think we have a lot of good things to hear from her this morning. Please give a hand. Next, we've got Dr. Jane Masiga. And please, I'm not sure everybody knows you. Anastasia, please greet the people. Yeah, we cannot take that for granted. So next is Dr. Jane Masiga. Dr. Jane Masiga is the Managing Director for MEDS. Yeah, so those of us in the sector, I think we know MEDS very well, but Mission for Essential Drugs and Supplies. Jane has an extensive 34-year career, coming from practice. She started at the practice level, has gone in to serve in pricing committees, in the Pricing Advisory Group of Africa, is a member of the National Advisory Group for Pharmaceutical Sector Assistance in the Ministry of Health, and today is a member of the National Technical Working Group for Review of Kenya Essential Medicines List. So extensive practice, as I say, ground up, and got into the leadership side of things. So again, definitely a great story to tell us. Then we've got Dr. Sylvia Vito, who is currently the Regional Director and General Manager for the East African Cluster of Countries for AstraZeneca. I don't know how that is in your business card, but Sylvia, it must be this big, isn't it? Yeah. She has worked in healthcare and pharma industry, driving commercial and infrastructural developments, and investments in key therapy areas of metabolic disease, rheumatology, oncology, and NCDs as in general. She has a 15-year career, ladies and gentlemen, serving in big pharmaceutical companies, AstraZeneca today, GlaxoSmithKline, Hoffman, La Roche, and all across the sub-Saharan Africa area. So please know that Sylvia is passionate about leadership and empowerment, and health, most importantly. Please give her a hand. We next have Dr. Catherine Canary, who I have met today. Pleasure to meet you, Catherine. Catherine is, I think, the odd one out of this group. Well, you can join me there, Catherine, but I'm non-clinical. She's a physician, by training. She comes from AMREF Enterprises, which is part of the AMREF Health Group. Her role there is clinical business lead. So at the end of the day, she has to look at the social enterprise sustainability for AMREF as an organization. And currently, the project that she's working on is an access-driven initiative around the pharma area on the retail side. So this is looking at how do we use containers and put them in strategic points to drive access. So I think somebody worth talking to, depending on what your area of interest is. And she's doing very, very serious things there. Formerly, she used to work in PSK, not this one. That is Population Services of Kenya. Yeah. So please do not mistake the two PSKs. Huh? And she has got 12 years of experience working in NGO, public and private sector. So again, multi-sectoral. So please give her a hand, please. Last but not least, our boy child. Dr. Timothy Panga, who I'm sure is known to all of you.
Yes.
Yeah, please give him a hand. Besides sitting on the NEC, as I saw him in that picture over there, so he is in part of the leadership of PSK. He serves as the CEO of Nyanyuki Teaching and Referral Hospital. As a clinical pharmacist by training, and which is his area of passion, to be very frank, quality improvement is something I believe is close to his heart. Looking at his credentials, ladies and gentlemen. And from what I can see here, he champions that quite aggressively. But of course, on a day-to-day, he runs a hospital. Yeah, not a mean feat if you ask me. So he's hands-on in the healthcare leadership in the public sector. And Nanyuki is actually the largest referral hospital in the Laikipia County of Laikipia. So I'm sure there's lots to share, give us lots of perspective, especially from that public sector angle. And Dr. Karibu, please let's give him a hand again, please. So, to my panelists, we're here to have real talk. We're here to have what I probably call a bit of a different kind of conversation. And let's just hear what you think. So I've got a few questions I'm going to throw out there and ask the panelists to respond to that. And the first one is, we have got this word UHC. It has a textbook definition. But if you ask me, as a person who is involved in healthcare, UHC seems to be all over the place, to be very frank. At some point I even wonder, what exactly is this thing? It is fashionable today in healthcare, I must call it what it is, to talk about UHC. Because it's the buzzword, isn't it? It's the buzzword, ladies and gentlemen. But the question is, what is it? And I'm not looking for a textbook definition. I am looking for what you think. And when I ask for what you think, I'm looking at where you sit today as a leader, number one. Two, what you think will work for Kenya. And three, most importantly, where does the pharmacist come in? Or should come in? So it's a bit of a loaded question. You can answer it in any way you want in those three areas. I'm not going to prescribe. But just give us your perspective, ladies and gentlemen. So let me start with Dr. Nyen. Please. I hope the microphone, I'm not testing your microphone, so I hope it's, we're good. Yeah? So Anastasia, please give us your perspective as quickly as you can.
So thank you, Mark, and good morning, ladies and gentlemen, fellow colleagues, as well as all protocols of that. My name is Anastasia. I chair the Kenya Association of Pharmaceutical Industry on transition from buyer until the end of July. Yes, it's been an interesting journey, I must say, and the questions that you're asking today are very pertinent. And I've just noted a couple of them. You're asking us as pharmacists. So the first one is your visibility and visible. I'll go back to the aspect of UHC. It all ties together because, as the saying goes, if you're not at the table, you're not sitting at the table, then you're probably on the menu. So we need to be very, very clear that we are actually sitting on the table of UHC, or the table of wherever anything on healthcare is being talked about. If you look at what LSK has done, any single thing along, actually they're everywhere. Why are we not everywhere? And I'm beginning to see beyond capping, where else as pharmacists, where else as an industry can we participate on the table? And for me, this is the journey that I want to walk next, that beyond just capping, which is pharma, where else can I as a pharmacist, as a leader in the pharmaceutical industry, as a leader in the healthcare sector, where can I participate? Now, UHC presents a very opportune perspective at the moment because it's a buzzword. It's the SDG, agenda for everybody. Until 2030, we are talking about, UHC, and WHO is pushing everybody, all the countries, member countries need to make sure that they have UHC by 2030. How it's going to look like and feel is purely dependent on a lot of things, including things to do with policies. So we have to participate in the policy aspect in whichever area that we are, but beyond, and not just in the healthcare sector, because when you go to Private Sector Alliance, they're talking about healthcare. Are we there? Yeah? Are we there? And yet they're shaping the policy, they're advising the country, because they're known as a private sector voice in the country. So that's just as a way of introduction, as a way of where I see as, beyond just this one group, beyond pharmacists, just alone here. We are comfortable, we're experts, but beyond that, so what? But just to start off into the UHC topic, a bit of facts that half of the world population doesn't have full coverage of essential healthcare, and that's an important fact. About 100 million people, yes, the second fact is that about 100 million people are pushed into poverty every year because of out-of-pocket spending on healthcare. Yeah? And then 12% of the world population spends at least 10% of the household budget, 10% on healthcare. Yeah, this is impoverishing. Of course, I've talked about the SDG number 3, and when this buzzword comes across, of course, we get all sorts of people coming out because it's an opportunity to make money. Yeah? But for us, it should be an opportunity to be involved in shaping the policy and creating the change so that, as pharmacists, we are visible and we are the go-to profession in terms of, when you're talking about UHC, where is the pharmacist? We need to consult the pharmacist because he's not only an expert on the pharmaceuticals and other related products, but he has a lot of contribution to make in the policy aspect. So, from what I have read is, what is UHC? So in UHC, it's about people receiving healthcare that they need without suffering any financial burden or hardship, and it covers the entire spectrum. I know there's this thinking of only focusing on, especially the medicine, because everybody says that medicines are too expensive. The bill takes about 60% or 40% of the hospital bill, as I've had in the insurance sector. They say it's medicine. But that's not UHC. UHC is the entire spectrum. You have to promote, you have to prevent, you have to cure, you have to palliate, because there's a need across the board. And then also it's about financial protection, because we know there can be unexpected illnesses, accidents do happen, and we know relatives, friends, colleagues who have gotten into situations where they had to fundraise, they cannot afford because of unexpected bill. So UHC is looking at how can we ensure that such things, when they happen, the persons or the relatives do not suffer any financial hardship. And then, of course, we know that good health allows children to learn and adults to earn, and that's an economic empowerment aspect, very important. I want to just quickly touch about what it is not. Yeah? It's not about free coverage for all disease areas or all interventions, but it's about scaling up. You have a package, but scale it up. Scale it up. It's not about minimum package, and also it's about population-based services beyond health, water and sanitation. Yeah, health campaigns, mosquito. How do you prevent diseases from happening, like malaria and so on and so forth. So for me, it's about equity, development, priorities. You have to set priorities. We know that WHO has set up priorities of UHC around the area of SDGs, infectious diseases, and so on and so forth. So where are we as a pharmacist, and where can we create a change? So I think, just in summary, from my perspective, those are my comments. What is the role of the pharmacist? We have to be visible, we have to be strategic thinkers, we have to be involved we have to be advocates. We have to be advocates. So that's what I would sum it up.
Okay, thank you for that, Anastasia. I'd like to go to Timothy for his angle. I mean, he's in the thick of things. You know, public sector, on the provision side. You know, let's hear your perspective, Timothy.
Thank you. I think Dr. Nyalita has explained for us everything what UHC is. I'll just add that UHC is accessing quality healthcare anytime. And this year's theme clearly communicates that our theme is pharmacists championing quality healthcare in UHC. So my feeling is the access of healthcare at any time, our responsibility of pharmacists, as we've been mentioned very well, as we are providing care, care has a cost. And UHC is ability to get that without any need for money at the point of access of care. So our role as pharmacists, as believe, centers around that bit, where we ensure financial protection of people, our patients, people who access care in our health systems. We also need to do something that is never mentioned. The only way to guarantee financial protection of patients as a result of high cost of healthcare is for you also to contribute to protecting your own employer from, financially protecting your own employer, because your employer also incurs costs. If you are working in a supply system, protecting, doing everything, becoming efficient, efficiency in healthcare and elimination of any kind of waste, in my view, is also a way we can contribute as pharmacists on the financial protection, because that applies everywhere across the board, from at the point we are delivering care in the hospital, all the way back to supplying, and finally even up to manufacturing. So I believe we are at the center of the implementation of UHC. And I just want to mention, we say that if people saw this beat, the panel discussion, I was not actually the only boy. Yeah. My own mentor was part of this, but he couldn't make it. Dr. Robert Nyarango, who has worked under, and I feel very proud to represent him, the boy child within this forum. I think we are really. I think this is a time when the pharmacist role will become more prominent. Thank you.
Thank you for that. Please give them a hand, ladies and gentlemen. For those of us who follow UHC discussions a lot, we see that one of the organizations championing this conversation extensively is AMREF. Extensively. Yeah. Whether it is at a global level, whether it is at a national level, they seem to be ever present as far as this conversation is going. So I will ask Catherine, to give not necessarily the AMREF perspective. You see, you're in there, so you can't. It's going on. What is your view? And you're coming now from a different sector of healthcare. At the end of the day, you've heard from Anastasia, supply chain, the big, side of it, the provision side, Timothy. Now you want to hear from, the development partner side of it. And let's hear what your perspective is.
It's interesting to speak after such great CVs, so it's also humbling. I'm not a stranger, particularly to the pharmaceutical industry. Indeed, my introduction to the medical field was as a medical assistant at the age, as a pharmacy assistant at the age of 8. So child labor exists. And so my mom ran a community pharmacy when I was growing up. Yes, AMREF has been championing the UHC agenda. Big shoes to fill. Our CEO, Dr. Girenji, is indeed the co-chair of the international conversation around UHC. And big conversations going on, many people at the table. So from my perspective, I would say first and foremost, the pharmacists need to put their skin in the game, because we don't feel them as much. In terms of at the global level, we know IFP-MA is in there with a bit of controversy, but they're in there. with their own agendas. So we
Stacey,
feel,
relax.
yeah, but as she said, I think we need to also begin at the local level. What is UHC to Kenyans? And when you look at UHC, personally, I look at it as how UHC will feed into the existing system. We cannot reinvent the wheel. We have systems existing. We have several layers of healthcare services, starting all the way from level 1, which is what Dr. was mentioning. We have the community level, and pharmacists play a role at all the levels. So we have at the household level, and in terms of an organization like AMREF, we're very strong on community health systems and championing the community health workers to indeed fill a gap that is felt at level 1 side of supply for our communities. And so many facets to UHC. Pharmacists definitely need to stand up and be on that table, because without that angle, the cog cannot move. It's a major cog. And this also goes up to the supply level. So we're looking at supply from level 1 up to level referral level of health services. And so my take is we need to hear from pharmacists. We need you at the table, because in terms of even, as you said, majority of the expenditure is viewed as from the pharmacy side in terms of use of health services. So these are discussions and conversations that we need to have urgently. And moving forward, remembering that at the end of the day, we're serving the Kenyan person. That is you, that is me, that's my relative back in the village. And so it is necessary that for them, anytime they think of an illness, the pharmacy plays the biggest role. They have to go home with medicine. This is at the community level, and this is who we intentionally end up serving in this medical field.
Okay, thank you for that. Give a hand, please. I'm going to go for a pointed response, because we've got the two ladies remaining who haven't spoken are deep in the side of supply chain. You know, and you heard what Catherine has said about what is the Kenyan belief. I must go there and get some dawa. If I haven't gone and gotten some dawa, I very easy got treatment. You know, that's a mentality of what? Society. There's all this accusation about the cost of medication. You're sitting in leadership, ladies. You're in the supply chain deep in it. Yeah, this is your trade. You're pharmacists. Yeah, so instead of defining the which I think has been well answered, this is now the contribution side with your supply chain hat of what should the pharmacist do to ensure that UHC works. So Dr. Masika, please.
Thank you very much. Thank you very much, and I'll start with something which happened when we were coming up this fall. We met a Mzungu, an elderly lady, and asked us, what are you doing here? I see many of you. We said, we are pharmacists. And the lady says, oh, looked at us with a lot of respect. I was with another pharmacist, and said, you are pharmacists. In UK, pharmacists are the ones who are in the first level of care. If you have anything, you go to the pharmacist first. And they are encouraged to go to the pharmacist before they go to the doctors, because then they can decongest the practice. So I was just wondering as I came down, if you found somebody out walking on the streets and you asked, you said you're a pharmacist, will you get the same expression in Kenya as we are here now? And that will answer the question the president was asking. So we can reflect, will the patients be saying the same about us? So I'm looking at UHC, and I'm not going to define it because it has already been defined, but from our perspective, we are looking at it as maybe a challenge and a threat to our profession. Why am I saying that it can be a challenge and a threat? Because we are dealing with some faith-based facilities as meds, supplying them medicines. We've done that over years. Some of those facilities have been there for over 50 years, even 100 years. And when we talk about the 4 counties where we have UHC being piloted, they are saying they are closing down because they are not getting patients. All patients are going where the UHC is, and they were not involved in the implementation. So I'm looking at the pharmacists and saying, those who are in those counties, aren't you already feeling the impact? Because they're going for free health care in the health facilities. What I'm trying to say is that if we don't position ourselves on the table when discussions are going, we'll be chasing a vehicle which is going and our profession will die. I'm looking at pharmacists taking strategic leadership where UHC is concerned. Let's not be just players, we take strategic leadership and position ourselves. And in strategic leadership, I think we need to consider that we have to have the knowledge. We have to empower ourselves, capacity building. We can't be the way we left university and we are saying we are going to be leader in here. Nobody is going to respect you. So can we keep on updating ourselves and even understanding what is it that we are handling? I'm looking at leadership where we have to be resource mobilization as a profession. Leadership and resource mobilization, because without resources, we cannot do anything about UHC. I'm looking at where we are talking about partnerships if we have to survive in UHC, but I'm also looking at the human resource capacity. We really need to think that we are going to do capacity building in and mentorship, and I think that was addressed before. We have quite a number of young pharmacists who are coming up. They are struggling, they are positioning themselves, but they can't fit in because it's too much for them. And we are just thinking that we should do some mentorship for these pharmacists. And we as MEDS on our side, we have taken up that role because we know it's a challenge for the upcoming. And we've had pharmacists, we are picking fresh graduates and taking them through leadership training. Because we believe pharmacists are leaders, not just working there. So pharmacists are leaders, we are training, and as we are speaking, we identify their talents and be able to position them very well within the supply chain where they can make their contribution and fill their role. As we are talking, we have 4 of them who have passed through that training and are among us here, and they've taken up their position. And they are the future leaders where supply chain is concerned. We have also taken up, I'm giving examples because that's where I've been most in MEDS. We have taken up county pharmacists who are, when the counties were formed and they were really trying to see what do they do. We got the county pharmacists together, we trained them in quantification and forecasting of commodities because that's what we should do. So that one, we have taken that role and we've done so. This month itself, we are in Makueni County and we are training in commodity management so that as we are moving, the pharmacists we are not left behind, but we have a role we can play in commodity management. We are thinking that we should be able to set standards as pharmacists. We should set standards and others should follow. There are standards which are recognized, things like MEDS, we have the ISO certification, we have the US OFDA, which means we can supply to all the US programs, funded programs. We have the ECO certification, we can supply to all European funded programs all over the world. Why should we set standards? The people or the system should have confidence in what we are doing because the standards have been set. So we should put standards there, and we should guard against substandard products because I think our business is also being killed by substandard products. And there are other ways where you can do, because you are saying as a pharmacist, what can we do in our small pharmacies? There's technologies which have come up like neon infrared style whatever practice, which you can use within the pharmacy. How do you do it? You can be able to test, but I'm not going how it works. but you can assure standards within the pharmacy or your workplace. And we have a med stand where you can go and demonstration on how you can assure quality in your own way can be achieved. We are talking about technology, leveraging on technology. Let's not be left behind. We've been able to do barcoding of the products, and we are saying we are going to actually try to raise the bar, that we are demanding that if you are supplying to meds, can you barcode your product? So that is already setting a set price that they will not bring us things which are not barcoded. Management is a problem and setting. We are talking about involving stakeholders in all networking with all other organizations. In East Africa, we are doing food procurement, faith-based organizations in supply chain. We are pooling all our quantities in East Africa, buying together so that we can be able to drive down the prices. We have partnership currently, and we are proud to say we are in partnership with KEMSA towards the universal health coverage. We've stopped where we are pulling all in different directions and working together because partnerships are very important. So I could go on and on, but I'm just thinking that as your UHC comes, then we also need to think about diversification. What are the gaps in the supply chain? Is it all the medicines we are chasing, or there are other things? And we realize that if we are just all of us concentrating on medicines, then we are leaving gaps which others will fill. And as we are talking now, we've launched the equipment. That is where pharmacists have not been going. We are launching equipment. We are saying, even as a pharmaceutical firm, we can distribute equipment. So those are the gaps you can see. And then there are other things like areas where we have neglected oncology, radiology. We are now supplying orthopedic implants. So let's diversify. Let's not all crowd in one place. And of course, with partnerships, we are partnering with the banks, and we are able to move. Lastly, as I finish, because there are so many points, we have to have integrity. We have to be leaders of integrity so that our profession can be respected. And of course, we should draw our strength and wisdom from God. Thank you.
I have to follow, but I know you to be tough, so do not be worried about that. But like what I said, we're looking for your perspective. Yes, you're in supply chain, different angle, definitely different perspective. So, and of course, you're a pharmacist. At the end of the day, you've got African experience, which I think is great. And yeah, UHC is not a Kenyan conversation. It's global, but Africa is our passion. We're Africans. So, what do you think?
Thanks, Mark. To me, healthcare is a human right and not a privilege. And we say it, but how many of us live that particular mantra that we hear being thrown around? We live in Africa, and the challenges of healthcare are very evident to all of us. I'm in the private sector, and when you raise the question of pricing, people think, okay, pharmaceutical companies, why are the prices of medicines high? When I look at my role as a pharmacist, my role as a leader in the private sector, UHC is a moral and a strategic obligation I have. I'm passionate about it because at the end of the day, why is it that the public patients who walk into Kenyatta or to any other county hospital cannot get that quality medicine from AstraZeneca, from GSK, from Pfizer, or wherever it is? That is a challenge for everyone in the private sector, and it's something that we are working on delivering. So I'll point out some of the things that we have done, because we are beyond pricing. We have a big responsibility as private sector, as a pharmaceutical industry, to do things around prevention, whether it's NCDs or communicable diseases. It is our moral and strategic obligation. We're not here to provide medicines for treatment, but to support government, to strengthen the current existing systems. So I'll point out a couple of things that we've done in the last 3 years. I've been at AstraZeneca. With the rollout of UHC, the first 4 pilot counties, we've gone ahead and signed up memorandums of understanding where we as an organization are going to invest in awareness programs, because unless you reduce the cost of treatment by preventing the diseases from progressing or prevent them from happening in the first place, you will not have supported government adequately. So awareness initiatives which we do through our third parties, and I'm glad AMREF is here. We've been running for the last 5 years a Healthy Heart Africa program where it's all about hypertension, and you know that they're actually on site as well. We are replicating similar programs in diabetes, similar programs in respiratory diseases as well. So for the first 4 counties, UHC counties plus another 15 that will follow, awareness initiative fully funded by us to see what can we do to support these particular counties, strengthen the systems around educating the public around prevention of some of these diseases, NCD specifically. Secondly, we've invested in capacity building. And capacity building starts from the grassroots level. I know AMREF has been very keen to talk about community health volunteers or community health workers. We talk about nurses, we talk about medical officers, but the role of the pharmacist. Because when you look at any level of critical care, the African patient, the average African patients, the first point of contact is actually the pharmacy. Because for us, consultation is a luxury that we can't afford to the majority of the public patients. So you find that we as an organization, we in the private sector, are deliberately now stepping up to see what can we do to support the first point of contact, whether that is the pharmacist, depending on the location, that's the community pharmacist, whether those are community health workers, whether they are nurses, whether they are medical officers, clinical officers. We've already rolled out these initiatives in the first 4 counties. So capacity building, we have a clear obligation, and not just stop it at that, but also escalate it to see what more can we do to drive up more specialists wherever they're needed. But we feel that the biggest gap is around the primary care and around the general practitioner, so to speak. But I think there's also a big role to say, where does the pharmacist come in and what can we do? I know we've initiated conversations with PSA around what we can do to roll out programs to educate pharmacists deliberately and continuously around the NCD space. The last, which is of course the passion of many people when they think of private sector, is access to quality care. We've stepped up, and I'm proud of companies that we serve in. I would want any patient to walk into a county hospital and they can find quality medicine, not just what we would call generic medicine. We've partnered with KEMSA and we've partnered with MEDS. MEDS and KEMSA are the biggest providers of treatment, so to speak, to the public patient. We already have for the last 2 years a rolling program to provide all our medicines at almost more than 70% of the current price that you and I pay when we walk into a community pharmacy. Because we're very cognizant, unless we lower the cost to the government, unless we lower the cost to KEMSA and to MEDS, on condition that this is not passed through other supply chain models. They have to supply directly to the point of contact for the patient. But on our side is also to ensure, what are we doing to make sure that they're also not buying from 3 other partners? We will supply directly to KEMSA, we are supplying directly to MEDS, so that we reduce the cost of the route to market, so to speak, because the more players are in between, the higher it is for the public patient. So I've talked about 3 things. Our contribution to awareness, because that contributes to prevention and lowers the cost of UHC, our contribution to capacity building, and our contribution to quality and affordable, because UHC is about providing appropriate care to all the masses that require it. So I believe we've made steps. The last 2 years have been, it's hectic, because at the end of the day, we are a private organization, so it has to be funded from somewhere. So we are keen and we are cognizant that we need to do what we do very well. Lower the route to market costs involved, partner with government, because it's no longer even a choice if you're in private sector not to partner with the public sector. So MEDS and KEMSA have been very critical, and we continue to do more. But at the end of the day, I'll always insist it is our obligation in private sector to make sure UHC works, because it is the future for our continent.
Quite passionate, quite passionate. Thank you for that, Dr. I want to switch the conversation a little bit. Not a little bit, a lot. Leadership. I believe and I know leaders are made, not born. I have reference to the fact that pharmacists that are made represented in this room and others who didn't come today undergo lengthy, rigorous training. Jane has reference to the fact that they have a bit of an incubation program going for leadership within the sector, which I think is great. It's a great initiative. Great initiative. But the question is why are there few leaders from this highly intellectual group in the forefront? Why are they so few? Are you limited to leading within a technical area, or can your leadership broaden into other horizons? So the question is, from a very personal perspective to the colleagues sitting here, and you're all clinicians, it doesn't matter what your training is now, just to include you in this discussion, Captain. It doesn't matter, because this is sectoral as far as I'm concerned. Is that one, I do not believe that the healthcare leader should only lead in healthcare, no. I believe the healthcare professional is well positioned to control the discussion of society. Because health is a pillar of society anyway. People listen to you, because what you have to say is serious. We come to you at our worst and expect you to take us back to our best. You heard what Louis said. The last parliaments have always made a law on this sector that makes your life difficult every 5 years. But where are you in that discussion sitting in parliament? If I put it directly. You say that, are you in there fighting? Or you're waiting to be told what to do? Where are the pharmacists? Where are the leaders? Why are they not coming to the front? What is your personal view, ladies and gentlemen? Representing gentlemen. Just to make sure I put that in there, Timothy, yeah? So let's talk about it, yeah? Now, this is personal. You're not representing, you're only talking about you and your profession now. And after this, we're going into Q&A, ladies and gentlemen. Because it's important to hear what you want to ask these colleagues. I'm not limiting, it's a leadership. So, let's ask the hard questions, guys.
Want to lead beyond your...
Is it working?
If you want to lead beyond your profession, it's something that I personally noticed that always wants. First of all, your personal integrity and people's perception of your competence must always be obvious and unquestionable. And your personal competence comes from commitments from what you have achieved in your own training and what you can do within your own profession as a pharmacist. And then that can now go on to the rest of the healthcare. And as I mentioned earlier, I know sometimes, when we go to leadership aspect, we speak in abstract. But I still believe you need to first know what is your mission in the space you are in. I'm in a health provision field, and I believe a pharmacist's role and my own role is to improve efficiency. That one does not, that one is, you can't negotiate on that. And you've got to reduce on waste. And our leaders in the supply chain side have already assured us about what we can do as pharmacists to have an impact to the other society so that we can be leaders that we are recognized about. Everyone talk about poor quality medicines, people talk about counterfeit. Let's close this discussion. Let's see leadership from pharmacy sector that there is no, when we get delivered as providers, we don't assure quality, we don't do quality control, we don't manufacture. At a provider level, there should be an assurance, and this industry should provide that assurance that what arrives at the point of care is proper, is quality, and is unquestionable, and the leadership will come from here. When people know we can do that, we control the entire space, because everyone, including at the center of politics, talks about this thing. And part of the reason why this frustration in the political space is exactly on the same thing. We need now to move on to visibility of the entire chain. People need to know, end to end. We need to know. We should not receive things we don't know where they started from. And that is very common. At the hospital level, our leadership, when we move to leadership, you must meet the aspirations of people beyond your own constituency. And it always starts with, I keep on saying, we start from home and then build outwards. What are areas where we as pharmacists must lead within so that we can lead even beyond pharmacy? overuse of medicines, ineffective, inappropriate use of medicines. That's what we need to address that. We need to address overuse, and you know we play a big role. Overutilization of healthcare. People staying in the hospital for too long because probably you didn't play your role very well. Health system leakages, the waste, the corruption, the fraud. We must not be part of it. Actually, that's a big thing. When I listened to her talking about access programs from AstraZeneca and other organizations, when those medicines and access programs arrive at us, and for some reason they leak out of where we are responsible for, they are meant for a certain segment of the society. There are already other supply chains that exist for people who don't go to public sector. So what I can do to frustrate their intentions is let things that are meant to be utilized by that segment pollute and frustrate the careers of other pharmacists who are in private sector, who have other patients who can access, when what is meant for that access programs accesses the normal change, we have already, you know, the integrity is lost. And I think that is it. Now, once you've established yourself as the leader beyond where you had professional competence, maintain it and be fair. Everyone keep on improving yourself. And I think anybody who takes a position of leadership must always use any opportunity available to them to show that leadership and build themselves. And nowadays there are so many resources for leadership, for learning how to lead others. You know, even when you're driving in your own car, you can listen. You know, you can do many things. I'm just saying, show it and be step forward. And I can say now that we are not few anymore. You know, that if you asked us 7 years ago, that discussion might have been very valid. Pharmacists are present everywhere. When there was devolved governance and positions of leadership were up for open competition, pharmacists increased suddenly. So that tells you something. Pharmacists were not present because there was no competition for positions. And you can see we have so many leaders in this world, in public system and also in the private sector, all kinds of sectors, because you know, I think we have equal chances as anybody else of any training, and we should capture the space. And once we are there, your constituency broadens. It's not your profession, it's everyone who is under your care. That's how you preserve the integrity. Thanks.
Okay, so thank you for that. Thank you for that, Timothy. Give me a hand, please. Timothy talks a lot about personal example, upholding integrity. You know, doing what needs to be done. Great. In one of the healthcare forums I'm in, somebody shared a link today that is in today's Standard. And the title of the article is as follows: Our dysfunctional health sector is in dire need of immediate attention. Today. I'm going to give you the conclusion of that article. This is the last paragraph. The medical sector calls for serious attention, if only because a healthy nation is a working nation. A working nation is a prosperous nation, hence higher levels of contentment. To doctors, primum non caring. This is a very accusatory statement, in my view, to us in the clinical sector. Very accusatory. When do these articles stop? When does it stop? Because even for me, who is a healthcare professional by management, this irritates me greatly. But this is happening under your watch, guys. I'm telling you. Your experience, you've been there, you've seen these things, ladies and gentlemen. But why do we allow these things to persist? I am happy, Timothy, you said, we are coming out. But what we do is what we get remember, at the end of the day, when they talk about you, it is what we call a status quo statement. It damns everybody, unfortunately. So this is a national article in a national paper talking about what we didn't get right. Are we starting to see action being taken? Yes and no. Yes and no. So that's about how much noise is there, and then the authorities come in. But leadership, ladies and gentlemen, leadership is what it's all about. This is leadership negotiation. So, because time is not our friend, and it isn't, and it will not be until we make it, and somebody will teach us how to do that. All good things do not have an end, but have a continuous conversation, in my view. Yeah? So, while we have had this discussion, I want it to be a continuous conversation. And my recommendation to the President, yeah? This is a scientific conference. But leadership is part and parcel of everything that you guys are going to talk about today, and tomorrow, and the day after. Let me tell you. I'm happy that it's in the program today. Really happy. But I think it should be sustained. My honest opinion. It should be sustained that there is a breakout session for those who are in that leadership space that want to go and have more conversations around that. I believe it deserves a breakout. My recommendation. Yeah, well, by popular demand, but I'm under pressure here.
I know, but I'm very passionate about this profession, and you asked a very pertinent question. And why are we afraid to be? Why are we not there? So, and I said at the beginning, if you're not at the table, then you get eaten for breakfast. Now, we are not telling our story. That's the problem. And we are not telling our story because we are not feeling the pain as yet, as much. It's not painful enough. And this is where we need to get to. It has to be painful enough for us to tell our story, but let's not wait for that pain to come. We need to support the society to really start telling our story. Catherine will tell our story, and you can see when you tell your story, you get beaten up. You have to be prepared to get beaten up. She talked about IPMA. We are all in as Capi. We know what's happening in IPMA. I just laughed when she said what she said, because I know we are at the table and we are very, very, very loyal. Because they say we are the guys who, they do, But at the end of the day, everybody agrees with our position. And who is the winner? The patient wins at the end of the day. Because you have to have innovation. Yeah, you can't kill innovation. Now, the other thing as pharmacists we need to do is that we are our own enemies. We have to grow each other. Please, if you see someone doing something good, pat them on the back, support them, let's move. Please represent PSK pharmacists wherever you are at different forums. I'm telling you that I'm already taking the journey. Yeah. Please, let's work together. Look for mentors beyond the pharma sector, beyond the health sector. Look for leaders everywhere beyond the country. Yeah. Go wherever it takes, do whatever it takes to really, and bring it home. Don't just go and, bring it home and do the bit. Yeah. Knowledge is very important. Don't just be comfortable with your expertise in pharma. You have to be across the board, because that's the only way you will understand what they're doing out there. You will influence policy. At the end of the day, it's about influencing the policy so that you can actually have a favorable environment for yourself. So values and ethics, please, very important. Your networks are very, very, very important. Wherever you are, think global and act local. Make contacts global. Bring them down here and let them work. There's so much money out there. There's a lot you can do at the country level. So please, let's just do it. But ethics, bottom line. So thank you very much for that.
Thank you for that, Anastasia. And I will ask the ladies and gentlemen, please clap for my panel. Please, guys. Thank you very much for this lovely conversation, and we beg to rest. Thank you.